Welcome everyone to MCPAP's September Clinical Conversation. As many of you know, our clinical conversations take place the fourth Tuesday of each month from 12:15 to 1:15. I'm Marcy Ravitch and I'm the director of MCPAP. Today's topic is irritability and temper outbursts in youth, what the primary care practitioner should know. A few housekeeping things before we begin. This session will be recorded and will be available on the MCPAP website at www.mcpap.org. A copy of the PowerPoint slides will also be available on the MCPAP website under the Archive News and Webinars page under About MCPAP. We're going to ask everyone to hold questions until the end, at which point, well, you can type them in at any point. There's a chat box where you can type in your questions, but we will be doing Q&A at the end. If you need to be unmuted and say something or ask a question verbally, then please just send us a chat and we can do that. You're going to receive a very brief survey following the presentation. Folks have been completing these after prior presentations, which is really helpful. It's how we improve each time, so we appreciate you taking the time to do that. We're also adding another question this time, asking if you have suggestions for future topics. So we appreciate any suggestions that you might have. Also want to just mention that all of our webinars to date have been on the GoToWebinar platform, and next month we're going to be switching to WebEx. So just a heads up, you might want to test it ahead of time to make sure that you have everything downloaded and working appropriately on your computer before the next webinar starts. Okay, so today's distinguished presenters are Dr. Bruce Waslick, who we've heard from a couple times already, but I'll give a brief introduction. Dr. Waslick received his medical degree from Tufts University School of Medicine and did his residency at Tufts New England Medical Center. Dr. Waslick completed his fellowship in child and adolescent psychiatry at Columbia University College of Physicians and Surgeons. He is a child psychiatrist at Baystate Medical Center and the medical director of the Baystate MCPAP team. Joining Dr. Waslick today, we have Dr. Deborah Buccino, who is a pediatrician at Macony Pediatrics in Great Barrington, Massachusetts. Dr. Buccino received her medical degree from Harvard Medical School and completed her residency in pediatric medicine at Boston Children's Hospital. Dr. Buccino is also a member of the MCPAP PCP Advisory Committee. And thank you both for facilitating this webinar for us. We're going to turn it over to you.
Okay, well, I'm going to start. This is Deborah Buccino. Bruce and I had a conversation last week just trying to hone in on what pediatricians struggle with around these issues of irritability and temper outbursts, which are certainly very common presenting concerns, I think, to all of us. So I was hoping that Bruce could give us an overview of just how to think about when these types of symptoms present. I know myself, I have a tendency to think, oh, this is just a behavioral kind of issue, but I think there's really, after talking to Dr. Waslick, there's a lot more behind it.
Sure, so I'm happy to be here today and talk a little bit about this. This is a very complex area, and it's kind of evolving in terms of our understanding of irritability and temper outbursts in kids. I am going to share a little bit of how we think about things from a psychiatric standpoint, but I'm really gearing this more toward helping primary care docs with what to do when a parent comes and talks to, brings the concern that their kid is either very irritable or having a lot of outbursts, and what are next steps? What can a primary care doctor do? And what really needs to be kind of referred to specialty care, child psychiatric practitioners. So I'm hoping that this will become clear as we go along. Just to get started, so I did want to define some terms. So, and some of this is kind of my personal take on the field. It is evidence-based in that sense, but it's how I've come to sort these different complex issues out. So when I think about the word irritability, I think of that primarily stemming from an emotional standpoint, as an emotional symptom. and using that as a term to think of somebody who's prone to anger, the emotional experience of anger. And I do distinguish that to some extent with temper outbursts. Temper outbursts really are more of the behavioral manifestation. There's often anger at the root of it and irritability, but the temper outbursts really have more behavioral manifestations when they're acting out their angry feelings, either with verbal outbursts, physical outbursts, aggression, or destruction of property. So I did want to make some distinctions between those two concepts, because those will be important as we move forward in thinking about how to deal with these different types of problems. Irritability and temper outbursts really are frequent presenting symptoms and concerns and refer children especially to specialty care. So this is a frequent reason kids come to see us in child psychiatry, and it's a frequent reason for referral to psychotherapy. I have to say, I think that I spend about 40 to 50% of my working day thinking about irritability and temper outbursts in the kids that I'm seeing, and it's a very frequent reason that kids get actually referred for MCPAP, either phone consultations or in-person consultations. And the other issue is there's a very wide range of presentation of symptoms. So on an emotional standpoint, experiencing transient irritability, which kind of comes and goes and is not causing a lot of disruption at home, but might be causing a lot of distress to the child, but also ranging to full-fledged temper outbursts and significant aggressive behavior. As you can see on the next slide, one of the important things, one of the concepts I'm going to try to bring here is that irritability and temper outbursts are relatively non-specific symptoms in child psychopathology, and they tend to cut across a range of disorders. So as we go through the next few slides, we're going to see where irritability falls in the diagnostic criteria for the different psychiatric disorders that we deal with in child psychiatry. So it's a prominent feature of mood disorders. If we could just stay back to one slide. It's a prominent feature of mood disorders, but we also see irritability and anger outbursts defined as essential components of certain behavioral disorders. Developmental disorders are not diagnosed because kids have irritability or temper outbursts, but kids with intellectual disability and autism spectrum disorders frequently come to the clinical attention of a psychiatric provider because of irritability or because of aggressive behavior. Trauma and stress-related disorders also have key components of irritability, and sometimes they can be the most prominent feature of these types of disorders. And irritability is not an infrequent component of certain experience of anxiety, and you can get temper outbursts with anxiety disorders. I'm going to be a little bit more specific in each of these different broad categories in the next few slides. So if we could move to the next slide. So this is a slide for mood disorders. So when we think about irritability, irritable mood is a prominent component for some kids who have manic episodes. So one of the main criteria for a manic episode is a distinct period of abnormally and persistently elevated, expensive, or irritable mood. And we're going to talk a little bit more about that down the road. But irritability can be a prominent feature of a manic episode. Major depressive episodes. So for the most part, we think of depression as being the experience of feeling sad, empty, or hopeless. But there's a specific criteria that is allowed for diagnosis of depression in children and adolescents, which means that you can substitute irritable mood for feeling sad, empty, or hopeless. So irritability is a prominent feature of depression as well as a prominent feature of mania. There is a new disorder which people may be hearing about in the primary care setting. We are certainly aware about it in child psychiatry. Disruptive mood dysregulation disorder, what we call DMDD. And this is a disorder that's been defined where one of the primary manifestations is recurrent temper outbursts. So and we're going to talk a little bit about this disorder as we go through too, but it's currently classified as a depressive disorder, and the primary components are severe recurrent temper outbursts manifested verbally and or behaviorally that are grossly out of proportion in intensity or duration to the situation or provocation. The mood between the temper outbursts is persistently irritable or angry most of the day, which makes this a mood disorder as opposed to a more transient reactive behavioral phenomenon. Next slide. So people are probably also aware that we have several what are sort of called behavioral disorders, but in DSM-5 are characterized as disruptive, impulse control, and conduct disorders. So one of the key criteria of a disorder called oppositional defiant disorder, which has been formalized in DSM-5, is that there is an angry and irritable mood. So, and it's further characterized by often losing temper, often being touchy or easily annoyed, or often angry and resentful. Conduct disorder, which is also in this category, presents with, at times, severe aggression to people and animals, destruction of property, deceitfulness or theft or serious violation of rules, all of which may have components of irritability or temper outbursts as a component. Next slide. There also is a disorder called intermittent explosive disorder, where the primary phenomenon is recurrent behavioral outbursts representing a failure to control aggressive impulses as manifested either by verbal aggression, physical aggression, and the requirement that 3 behavioral outbursts involving damage or destruction of property or physical assault occur against animals or other individuals occurring within a 12-month period. So these are all disorders that have prominent components of irritability and aggressive acting out temper outbursts, which are categorized in the disruptive, impulse controlling conduct disorders. Next slide. So again, I talked about this a little bit earlier, but one of the symptoms that frequently comes to clinical attention for kids who have developmental disorders, either autism spectrum disorder or intellectual disability, is when they are presenting with a lot of irritability, which can be a lot of mood swings, frequent anger outbursts, or significant aggressive behavior. In autism, there are actually 2 currently FDA-approved medications for the treatment of not autism per se, not the core components of autism, but irritability associated with autism. And these 2 FDA-approved medications are risperidone and aripiprazole or abilify. So developmental disorders, although irritability is not present in all kids with developmental disorders, is a frequent reason for clinical attention if present in kids with autism or with intellectual disability. Next slide. These are the trauma and stress-related disorders. So reactive attachment disorder is a very different disorder where kids develop extreme sensitivity to their caretakers and their relationships with their caretakers. One of the main criteria, again, here you can see, is episodes of unexplained irritability in addition to sadness or fearfulness that are evident even during non-threatening interactions with adult caregivers. Kids who've been traumatized frequently present with irritable behavior or angry outbursts. As you can see, the definition here for PTSD age 7 or older includes irritable behavior, angry outbursts. And in the next slide, you can see also the same is present for kids who are 6 and younger. So marked alterations in arousal reactivity, one component of which is irritable behavior and angry outbursts. So again, very different sort of categories of disorders. Next slide. We also have to think about the anxiety disorder. So one of the criteria for generalized anxiety disorder, you can see highlighted and underlined, is in fact irritability. So kids with anxiety, persistent anxiety, can present and experience significant irritability as one of their symptoms. And now these are very different diagnostic categories, but they all at different times can present with prominent irritability or temper outbursts. The clinician's job is really to sort out what's going on with an individual kid, and the best way to do that is through a diagnostic assessment. So my summary points of this section is that irritability and temper outbursts are relatively nonspecific symptoms present as diagnostic criteria in a wide variety of seemingly unrelated psychopathological categories in children and adolescents. And the starting point really is, the starting point for assessment and intervention is really a thorough diagnostic evaluation. I do want to give some ideas about this in the next few slides. So if we can go to the next slide. So I've grouped some of the disorders here that we've talked about. Again, you can see all these different disorders, all of which can present with different types of irritability or temper outbursts. But I do like to think in terms of diagnostic category. So the frequent issue related to irritability is the possibility that the child is actually experiencing a developmental disorder or a mood disorder. These are the second level broader categories here. Or to characterize them diagnostically with a disruptive impulse control or conduct disorder, or whether they've experienced significant trauma and really presenting more with a trauma or stress-related disorder, or they have a prominent anxiety disorder. Next slide. This is similar to how I approach temper outbursts, thinking broad categorically. Does the child have a neurodevelopmental disorder? Or is the information available more characteristic of a mood disorder, such as DMDD? Or in totality, the evidence and the evaluation suggests that they actually have more of a disruptive impulse control or conduct disorder, or whether we're dealing with significant issues related to trauma and stress-related disorders. Next slide. This is a quote from a colleague, Gabriella Carlson, who's a professor of psychiatry at SUNY Stony Brook, and I think this kind of captures how I think about this. Explosive behavior is like fever. You have a fever, if you have a fever of 105, you know the kid is sick, but you don't know what the kid is sick with. And so to me, those explosive outbursts means this child is in deep trouble, but what he's in trouble with really needs a diagnostic assessment. So that's an overview of how I think about irritability and temper outbursts, and it's somewhat different because it's not diagnostic specific. It really is taking into account the various potential psychiatric disorders somebody may be experiencing when they're presenting with these symptoms.
Yeah, thank you, Bruce, for that overview. I find it helpful, and just reflecting back as how I kind of am sitting with patients as a primary care pediatrician with these issues, one thing I'm taking away from this is that this is more complex than, I mean, I have a child who comes in, they're primarily anxious, they're primarily depressed, they have ADHD. I feel comfortable assessing, even starting some medications for those if that's what's appropriate. I have to say that in this realm, it seems that as you're focusing on the diagnostic assessment, I think I'm going to end up sending more of these kids to MCPAP, actually, because I feel like this is to cover all this breadth of trying to decide where these difficulties are coming from. I think it's probably going to be better done by an initial appointment by a psychiatrist, and then we can move from there. So that's one thing I took away from it. I mean, obviously, we kind of think about what's the severity. Maybe we would refer to a therapist first and get a little bit better sense of things, but that's one thing I'm thinking about. And then I also find myself thinking about what are the common things that come up when a parent is talking to us, having an initial conversation about these issues. One is they often bring up the concept of, does my child have bipolar disorder, because they are experiencing, the parent's experience of this kind of thing is often wide mood swings. So maybe you can just kind of tell us a little bit about how, as a pediatrician, we might reply to comments that come up like that.
Absolutely. So I'm going to address that in the next couple of slides. So this concept of pediatric bipolar disorder has been pretty controversial in child psychiatry. And it actually, there's been several changes to our diagnostic manual that really are trying to address how to appropriately define and characterize bipolar disorder in children and adolescents from some of the uses of the colloquial term bipolar. I don't know if this is common in all areas of Massachusetts, but sometimes when you hear that somebody has bipolar or is bipolar, you know, one of the things that people are trying to communicate with that language is that they're talking about somebody who has significant anger issues and anger outbursts. And as we said before, irritability can be a component of a bipolar disorder, but I would say that it's pretty infrequent that a kid actually meets full criteria for bipolar disorder if they're presenting with irritability. So in my mind, temper outbursts does not equal bipolar disorder in youth. Irritability and temper outbursts can be prominent symptoms in youth with a diagnosis of bipolar disorder. But the hallmark of bipolar disorder in youth or adults by DSM-5 criteria is at least one episode of mania or hypomania. So the next two slides will make this a little bit clearer. So this is the criteria for a manic episode as per DSM-5, and the language here is complex, but this is how we think about it. A manic episode is characterized by a distinct period, meaning representing, in general, a departure from the child's normal mood state of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy lasting at least 1 week and present most of the day, nearly every day. Or you can actually make a definition if the kid is so severe that they end up psychiatrically hospitalized within 4 days. You can call it manic episode at that time because of the severity. So there are some key components here. This is not kids who are just having temper outbursts because of frustration, tolerance, and conflict with parents or teachers. This is a mood shift. Something has shifted in the mood. It's had a persistence, meaning it's lasted at least a week, and that the mood state is clearly different than the kid's baseline emotional functioning. Next slide. And the other way to determine whether somebody has a manic episode and would be criteria for bipolar disorder is that they will have these other associated symptoms. So, you know, usually we would see at least 3 or more of the following symptoms. 4 if the mood is only irritable. They would be presenting with an inflated self-esteem or grandiosity, a decreased need for sleep. This is not insomnia. This is kids who are running around saying, I don't need to sleep. I got so much energy. I've got so many things to do. Sleep is wasting my time. Or that they're more talkative than usual, or they have a pressure to keep talking. Again, something different than how they normally present. They may be presenting with the subjective experience that thoughts are racing, or they're having a lot of ideas that are kind of going a mile a minute. They can be very distractible. Again, it may be important to sort out this type of distractibility, which is episodic, versus kids who have attentional deficit hyperactivity disorder, who have chronic distractibility. One of the things you often see with kids in a manic episode is that they have an increase in their goal-directed activity. They're doing things, all kinds of things, and engaged with schoolwork or making social acquaintances. They can also present with psychomotor agitation. And they also, at times, can present with excessive involvement in activities that have a high potential for painful consequences. So spending money, getting involved with different types of romantic or sexual relationships. In adults, we see foolish business investments, but foolish decision-making on the part of adolescents. Next slide. And so the other criteria is that the mood is sufficiently severe to cause marked impairment in their functioning at school, at home, with their families, with their social peers, and the episode is clearly not due to the direct physiological effect of the substance. So I think, you know, you can go by these type of symptoms in terms of understanding the difference between temper outbursts, irritability, and what is manic episode. I want to spend a little bit of time on the next slide talking about this new mood disorder which has been included in DSM-5, and this is disruptive mood dysregulation disorder. And this is a disorder that was actually included in DSM-5 really to make it clear that kids with mood disorders with prominent temper outbursts are unlikely to be experiencing a bipolar disorder, but they're much more likely to be experiencing a mood disorder with prominent irritability and outbursts. And it's been entitled the Disruptive Mood Dysregulation Disorder. So this is characterized by severe temper outbursts at least 3 times a week, and that they're experiencing sad and irritable mood or angry mood almost every day, and reactions to the frustrations that set off the temper outbursts are greatly exaggerated from what you would normally expect for somebody at their developmental age. Next slide. The child has to be at least 6 years old. So we're not making this diagnosis, and in fact I think it's very, very challenging for psychiatrists to try to make the diagnosis of mood disorders, whether it's depression, bipolar, or disruptive mood dysregulation disorder, in kids under the age of 6. For this to be classified as a diagnosis, the symptoms have to begin before the age of 10, and the symptoms are chronic. They're not briefly episodic. They are present for at least a year at the time of diagnosis. And the other issue with this, which distinguishes it, is that the child has difficulty functioning in more than one place because of the temper outbursts. So if a kid is having a lot of outbursts at home, but that's fine in school, it's unlikely that they're experiencing a mood disorder such as depression, bipolar disorder, or disruptive mood dysregulation disorder. This disorder, by definition, has to present with symptoms in at least 2 prominent environments in the kid's life.
Yes, that's a lot of helpful information. Thanks. I mean, I want to move on to another aspect that I find myself struggling with, which is in the younger children, more in the 2 to 4-year-old range. I'm wondering if there are red flags that can tell us that temper outbursts, how do we tell the difference between the temper outbursts, terrible two, that sort of thing, versus things that are really more pathologic and may need more attention and persist over time?
That's a great question. So let's go to the next slide. I've got a couple of things I think that are helpful to think about. So, ability to regulate oneself in terms of their emotions and frustration tolerance is really a developmental task. And there's some degree of fluctuating irritability and expression of temper outbursts that's probably in keeping with normal development. So we all are familiar with sort of terrible twos. Terrible twos, kids are prone to have sort of outbursts. They get frustrated. They're trying to figure out how to function in this world and how to regulate themselves. So very young kids experiencing frustration, tolerance problems, or temper outbursts probably are within the range of normal. Mood disorders are rarely seen in this age group, and if you are even considering making a diagnosis of a mood disorder in this very young group, you probably ought to get specialized consultation from a psychiatrist or a child psychologist or a child mental health professional. Rarely, if ever, should medications be considered in this age group, especially as first-line interventions, and that's because a lot of times that the irritability and temper outbursts tend to resolve as kids get older, as they begin to manage themselves better, as they begin to understand, how to communicate and work with the world and deal with tolerance and frustration in a more tolerable way. These kind of problems often get better, and sometimes it's just a matter of appropriate support and waiting for kids to grow up a little bit. There are also a lot of very positive psychosocial interventions, such as the positive parenting program that really aim to help parents manage kids who are presenting with these type of issues related to difficulty, frustration tolerance, or even aggressive behavior. And they're all around trying to set up consistent environments and praising kids for being able to develop skills in these areas. Next slide. I think some of the predictors of things that may last longer would include genetic diatheses in the family for mental illness, a very, very irritable temperament, which can be a hallmark of mood disorder in some kids, irritability manifesting as depression as the kids get older, attachment issues, sometimes when kids are really struggling to work out relationships with their parents because of various challenges, either innate to themselves or in the environment, can be a difficult problem. I think developmental delays is often an issue with kids who are trying to learn how to regulate their emotional self, especially as we get older. We use a lot of language to negotiate conflicts and get access to environmental resources that we need, and also to engage in self-regulation. So language delays can be a predictor of problems with emotional regulation, and other types of neurodevelopmental delays in development of self-regulation that we often see with kids with ADHD. Next slide. Some of the environmental factors that can predict more persistent problems with irritability and temper include growing up in a neglectful or abusive environment. So, you know, where kids are not getting their needs met, very problematic for kids to be able to develop sufficient emotional self-regulation. Sometimes in households where there's a lot of modeling of aggressive behavior or irritable-based behavior in terms of negotiating conflicts and dealing with relationships, that can be a problem. And at times, there can be unintentional reinforcement of negative behavioral patterns. So if a kid is irritable and they want something, they're demanding, they keep escalating their behavior because they want something, and the parents say no, 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 and then finally give in, you know, the kids will learn from that the way to get what they need is to, you know, up the ante in terms of their aggressive behavior. So parents who are, you know, perfectly good parents can, at times, unintentionally reinforce these negative behavioral problems, and that can establish a pattern and then lead to worsening behavior over time. So these are some of the factors. Most of the kids do pretty well over time without a ton of intervention, but there are some kids that probably need intervention and help in the family to be able to develop better self-regulation skills.
Yeah, thank you. That's, again, a lot of very useful information. I realize we're really presenting a lot of information, but I think it's giving us a good, as pediatricians, a good overview of how to think about this. And maybe in the future there'll be another webinar about getting into more detailed things. But I think another topic I would like to address is that, again, I feel very comfortable with straightforward depression, straightforward anxiety, and then once it gets into the behavioral type realm, those kinds of disorders, it's harder for me. So I'm wondering if you could say some about how we can distinguish what is irritability primarily coming from mood disorder, because if we can tease some of that out, then we'll know what medicines to start with or what therapies. I hate to keep going to medicines because I don't usually do that, but the therapy and medicines that would be helpful for mood disorder versus what are we seeing that really is leaning more towards something like oppositional defiant disorder, things that as a general pediatrician I tend to feel a little less uncomfortable with.
Absolutely. So if we go to the next slide, I've got a table here trying to give some, actually, let's see. Well, I have a table somewhere here. Maybe it's not. Yeah, I guess it's back. Keep going back.
Yeah.
Let me just say, I say that one of the most challenging issues is to sort out what is, you know, oppositional behavior, what's conduct-related behavior, versus what is mood disorder. And there's been a blending over the years in terms of these kind of difficulties. You know, sorting out something like oppositional defiant disorder. I mean, I think the way to do it is to think of it as it's chronic. It's usually manifested by a lot of oppositional behavior, a lot of doing things that shouldn't be doing, rule-breaking behavior. You know, frequently these kids are irritable, but it's not necessarily the irritability that's driving the behavior. It's actually sort of the opposite. They do things that are probably not acceptable in the world, and then they get called on it, or they get a disciplinary action, and then they end up being angry, irritable, frustrated, and this pattern sort of comes up over and over again. It is a very subtle diagnostic challenge to sort out which of the kids who are presenting with a lot of oppositional behavior and temper outbursts are actually suffering from a mood disorder or a precursor to a mood disorder. And I think that as we've kind of sorted things out over time, we are very much aware that the kids presenting with a lot of oppositional behavior, some of those kids are experiencing mood symptoms, and they're not able to kind of keep up their regular role. So that's a strong diagnostic challenge, and I think that's one of the things where you really hear about persistent, chronic oppositional behavior, frequent irritability and temper outbursts. Those are the times I think it's really hard for a primary care doctor to sort out, and that you really need mental health specialty consultation at that time to help sort out, because it's very nuanced. And I would even say that I spend a fair amount of my time thinking about the kids I see. Does this kid have a behavioral disorder? Is that what's driving the issue here? Or do they have a subtle form of mood disorder, and that's what's driving the clinical presentation? So they're complex. They overlap in terms of symptoms. They can be sorted out, but often need more specialized evaluations.
Okay, thanks. I know we want to get toward more kind of management issues, but can you just take a minute and talk about this slide as far as, are there certain things pediatricians should be thinking about when irritability is presenting in those with developmental or communication type disabilities like autism?
This is my,
Yeah,
I just want to say, for some reason, that slide that you were just talking about is not showing up on screen, but we will make sure everyone gets it. It is a really, I can see it in front of me on the printout, and it's a really helpful slide that you're all going to want to have, so we'll make sure that you get it.
So just briefly, I'll talk a little bit about the developmentally delayed children. One of the things I learned when I was taking care of kids with developmental delays is that because of different types of ability to communicate and express themselves, you may see irritability or temper outbursts as manifestations of different types of emotional stress, anxiety, physical distress, or somatic discomfort. And these kids really do need to be evaluated medically. If they're all of a sudden presenting with a lot of irritability and temper outbursts, at times it could be a manifestation of physical discomfort or pain that they can't communicate effectively. So I do think they need to be evaluated medically for any changes in their medical status. At times, these are transient phenomenon, especially with kids with autism, reacting to sort of changes in their environment or changes in the important relationships in their life. But it is a situation where if the irritability and the temper outbursts do persist, they probably need referral for specialized evaluation, because there are kids with autism and intellectual disability that do develop mood disorders, that do develop anxiety disorders, and at times develop different types of developmental issues. So irritability and temper outbursts that are more than transient, that last for a period of time, and you can't uncover a source from a medical perspective, should be referred for consultation from a mental health specialist.
Okay, great. That's really helpful. Now let's move to thinking about if you could give us an overview of how a psychiatrist or how we can think about medication for these kinds of symptoms. I do want to say I think we all tend to go to the more psychosocial treatments first, but since we have a psychiatrist in this webinar, let's talk some about medications.
Sure. If we go to the next slide, I mean, I'll give you my overview. So I think I think you'll probably know where I'm going on this, is that, determining the appropriateness of a medication treatment for temper outbursts and irritability really requires a very good diagnostic assessment. And I would say that the diagnostic assessment does help me think about medication treatment, because if I find an underlying diagnosis of anxiety, and I think it's prominently related to the irritability or temper outbursts, I'm going to think about medications that are helpful for anxiety. If I think that the kid is depressed and the irritability is coming out of a underlying depression, then I'm going to be thinking about treating the depression and hoping that the irritability and the temper outbursts are going to get better. If a kid is presenting with a developmental disorder with prominent features of irritability, I may be using a different class of medications and a different medication approach if I think it's primarily an issue related to a severe developmental problem versus a mood or anxiety disorder. So the best starting place is really to utilize evidence-supported approaches to treating the underlying psychiatric diagnosis if we can determine it. And the decision to use medication is generally a potential benefit versus a potential risk decision, taking into account the seriousness of the symptoms and the potential side effects of the medication. A wide variety of medications classes are used depending on the diagnosis, which the next slide is kind of complex, and it's really meant to just give you an idea of the different types of medications that you could conceivably use, all of which have some level of evidence basis depending on the underlying diagnosis. And so I've listed some of the medications here, like for autism, if the irritability and the outbursts are severely affecting the kids or the environment, you do have FDA-approved medications for treatment of irritability associated with autism. We have medications FDA-approved for treatment of depression if we think depression is the primary problem. We have medications that are approved for the treatment of acute mania, such as risperidone and Abilify and olanzapine and Seroquel. But these are actually only approved for ages 10 to 17 or older. Again, we do have an FDA-approved medication for generalized anxiety disorder, which is duloxetine. Now, duloxetine is never going to be anybody's first choice of medication to treat GAD in kids, but it does have evidence that allowed it to get FDA approved. Some of the other common disorders, we don't really have really great medication evidence that they're helpful. So oppositional defiant disorder, intermittent explosive disorder, disruptive mood dysregulation disorder, there are no established treatment there because it's such a new diagnosis. You know, we're sorting out as a diagnostic phenomenon, but we don't have a ton of treatment studies at this point suggesting that one treatment approach is another. So we know quite a bit about what medications to use in certain clinical situations. Other situations, we really have to, use off-label medication approaches if we think that if we don't have the evidence base to support our treatment decisions. So a wide variety of medications are used. We do use their underlying diagnosis as a guidepost, and then anything beyond that is clinical decision-making. This is, again, very specialized treatment, I think. I think you can learn to deal with some of the issues like anxiety and depression. I think that's pretty routine for a primary care doctor. But trying to treat oppositional defiant disorder, disruptive mood dysregulation disorder, PTSD or reactive attachment disorder, I think is above what we would normally expect from a primary care doctor.
Okay, great. And can you speak a little bit about non-medication ways we can think about helping with these issues of irritability and temper tantrums?
Sure. I'm going to just summarize some things here in the next slide. So psychotherapy, this is really not going to be something that you'll be doing as a primary care doctor, but you may be collaborating with therapists out in the community who are working to help families with these problems. So that I would say in general that the best outcome, if you're thinking about pharmacotherapy, but the best outcomes for most children and adolescents with these type of problems result from combining effective pharmacotherapy and effective psychotherapy. Psychotherapy targeting enhanced verbal expression of irritability or anger as opposed to behavioral expression of irritability or anger can be effective. I think this is one of the things that psychotherapy can do is help kids learn to verbalize their feelings. If they're verbalizing their feelings, they may be less prone to using physical aggression or violence in terms of getting their needs met. We do need to help families model and positively reinforce verbal resolutions of conflicts versus using behavioral acting out. So incorporating families into the overall plan of working with the kids is extremely important with this type of problems. And we do have some evidence-based psychotherapy, if available in your community, that can be helpful in alleviating the symptoms of underlying psychiatric diagnoses. So, for example, anxiety, we know, really responds to effective cognitive behavior therapy. It's hard to get cognitive, I'm aware, it's hard to get cognitive behavior therapy out in the community. There aren't a lot of practitioners who are specialized to use CBT techniques or specialized to use CBT techniques for kids. but you can find it, and CBT is not the only way to approach anxiety, but it is an evidence-based support. So if you see on my next slide, we do have some evidence-based treatments for different disorders. So we have evidence-based treatments for autism. Applied behavior analysis is probably the leading treatment in this area. We have evidence-based psychotherapies for depression. We have something called collaborative problem solving for kids with intermittent explosive disorder. This was made popular in a book by a psychologist called The Explosive Child. The whole approach here is a family-based intervention helping kids develop better problem-solving skills. And for the younger kids, especially with oppositional defiant disorder or the early onset of conduct disorder, really working with the parents to help them work with their kids to develop coping techniques, ways of negotiating conflict, and ways of appropriately seeking attention from people around them can be helpful. And this is usually done in a parent training model, such as the Positive Parenting Program, Triple P. So it's a dense slide, and I'm not expecting everybody to memorize it, just to let people know that psychotherapy can be very effective for kids in terms of dealing with anger, irritability, and temper outbursts, and that working collaboratively with a psychotherapist will generally enhance outcomes if you're choosing to medicate.
Yeah, thank you very much. I do want to move on to time for questions. I know we have a slide at the end that talks about resources that MCPAP can provide themselves. I also just want to put a plug in that I think eventually, I know Bruce and I talked some about this, but we just didn't have time, but if MCPAP can work on creating book family here, I only have so much time, I want to know I have a good resource online or a book that I can refer families to.
I agree, and I think that this is just a list of resources. And MCPAP consultations, phone consultations, in-person consultations, I think should be really helpful for primary care doctors, as well as the resources you're talking about.
Great. Well, thanks to both of you. I think that was a really informative discussion, and again, apologies for the missing slide. We don't know where it is. It should be in here, but we'll make sure that you all get it. So we do have a couple questions. The first one is, with the newer diagnoses of DMDD and IED, if the PCP is fairly confident in the diagnosis based on the DSM-5 or a MCPAP consultation, have others run into trouble getting reimbursed for those particular ICD-10 codes as I have?
That's a totally novel question. I'm trying to think. I have probably treated kids where I diagnosed intermittent explosive disorder, and I've probably billed for them. I've never heard anything coming back to me that it was a disqualifying diagnosis from any insurance company. So I wonder if that's an insurance-specific issue. And I would say the same thing for disruptive mood dysregulation disorder. Now, I know a lot of these kids present at sort of, higher level settings, such as in our partial hospital program or inpatient units, and I've never heard that being an issue. So that's a good question. I wonder if MBHP has any thoughts about that. I haven't heard that. It has never been raised for me. And I think one of the things that you want to do is, if you are confident about the diagnosis or you've gotten a psychiatric consultation, you want to be able to list it as a diagnosis in your encounter form and get appropriate reimbursement, because they are certainly bona fide psychiatric disorders, and they will warrant attention. So it's a really interesting question, and I have to say I don't know the answer to it.
I don't speak for MBHP, but I don't know the answer to that question either, and I would suggest contacting the insurance company and asking. And if you continue to have a problem with that, feel free to email us at what's our email? MCPAP at beaconhealthoptions.org. So sorry. So yeah, you can always email us if you're having a problem like that, and we can look into it. So the next question, I got pushback for the PCP making the diagnosis while waiting for specialty care. I think I got pushback for the PCP making the.
I mean, somebody thought that the
You know what?
primary care doctor.
I'm going to unmute Mary Beth, who's asking this question. If I've unmuted you, if you would like to speak. Mary Beth, are you there? Okay. Sounds like.
I wonder if they're talking about autism. That comes up for pediatricians, but.
Okay, well, we'll come back. I'll leave you unmuted, Mary Beth, in case you come back. The next question is, are there certain patterns of family dynamics that can pinpoint the irritability as related to environmental causes?
Well, you know, I didn't put a slide on etiology on this, you know, and I think that one of the struggles we have with all type of psychiatric disorders is really pinpointing a single cause. I think we usually end up sort of saying that when somebody's manifesting different sorts of problems or it gets to the level of disorder, it's usually multifactorial in terms of cause. So that often there are sort of genetic diatheses, biological diatheses that may set up somebody as being a risk factor for developing a particular disorder or problem. But it usually is in the context of other environmental concerns. So I think the question goes, you know, can we say that in certain families, once we get to know them, when we get to sort out the dynamics, can we see that some of the family dynamics are actually driving the kids' irritability and aggressive behavior? And I think that is the case in some cases. But I think the thing that I don't want to suggest is that the parents are causing the problem, because I think that is usually too simplified a way to move forward. You know, I think a lot of parents use different type of parenting interventions with their kids that are perfectly fine, that are going to be completely okay with the vast majority of kids they would ever have to raise. But there are certain types of parenting practices that, if used with kids with certain vulnerabilities, really tend to not work for them. And that's the whole idea behind Triple P, or parenting, positive parenting model, is that parents, once they're dealing with their kids with a particular problem, can learn very specialized parenting techniques that you would never use with most of the kids you deal with, but can be very helpful for kids who are prone to being inflexible or having difficult temperaments or prone to aggressive behavior. So yes, we certainly try to sort out dynamics. We deal with the dynamics within a family, but I think it's a little bit simplistic to say that the dynamic in and of itself is causing the problem.
Thank you. Mary Beth, have you rejoined us? We wanted to allow you to ask your question in person.
Can you hear me now?
Yes.
Okay. Yeah, somehow it dropped me when I tried to unmute myself, so I had to sign back in. So it was me who said about the ICD-10 problem, and I can't remember. It was actually 2 health plans, probably Mass Health and a commercial managed care, Mass Health. And their response was that, and I've had this for other diagnoses, that a PCP is not allowed to make some behavioral health diagnoses. So when I get it next time, I'll make sure I let you know. I did try to, I didn't get anywhere with it.
I can look into that. This is Marcy, and get back to folks about that.
So it'd be interesting to hear if like bills were being rejected if the practitioner was identified as a primary care doctor and using certain types of diagnostic codes. That would be new to me. I don't know that. It'd be very interesting and important to find out.
And we will research that, and we will put it in our next newsletter. Thank you. I think that's it. We don't have any more questions. So if either of you have last words, we have a couple minutes left. Last questions among the two of you that you might want to share.
I think I'm good. I thought it was, go ahead.
I was going to ask Deb, I mean, you know, some of the medications that we're using, I wonder how you feel about primary care doctors, so that if a MCPAP consultant said, you know, this kid's got sort of ADHD, prominent irritability, you know, maybe add an alpha agonist to the stimulant to see if that would help tone down some of the irritability and the outbursts. How comfortable do you think primary care doctors are taking those kind of more complicated recommendations around medication and trying to implement them as a primary care practitioner?
I think that's a good example. I feel very comfortable with that level of complexity. I mean, I think every primary care doctor is different depending on how much they've really gotten into these topics, but actually the guanfacine and clonidine add-on type things is something that I've directly learned from MCPAP and have implemented in very helpful ways. I just have my gut feeling, and maybe this is going to change with continuing relationship with MCPAP, but my gut feeling is a lot of hesitancy to go to the atypical antipsychotics and risperidol and things like that. But the SSRIs, ADHD, including adding on things like the alpha agonists, I'm good with. I mean, I think it's just when the medications start having more side effects, I feel like I need more psychiatric input. But I do think as our relationship with MCPAP and primary care, you know, grows and continues, you know, we may just start, each person builds on what they feel comfortable, and then they might be willing to take on a new medication with added support. And I like this concept that I know you guys are starting to move toward, of having one kind of site person, contact person that we can contact over multiple times over one case. I mean, I think to know that we can go back to the same psychiatrist is going to be a place that we can build our comfort level with some other medications.
Thank you, Deb. So we're going to end our webinar with that. That was a great plug for MCPAP. Thank you. Do want to stress that we recognize that different primary care providers have different levels of comfort, and we are respectful of that in our consultations. And the idea is, as Deb was saying, to sort of grow over time with your comfort level. So I want to thank everyone for attending. Remind everyone that you will receive a survey after the webinar, and we hope you'll take a couple minutes to fill that out. If you do think of any further questions, or you have ideas for additional topics, or need more information, feel free to email us at mcpap@beaconhealthoptions.com. As always, the recording of this webinar will be on our website probably sometime tomorrow, along with the PowerPoint presentation. Thank you to Dr. Waslick and Dr. Buccino, and to everyone for participating. Have a great day.
All right, thanks. Bye-bye.